So surgery and ulcerative colitis. Primary goal is to be well, alleviate the complications, alleviate symptoms, achieve and restore bowel continuity, and achieve best possible quality of life with a pouch. The decision to have a pouch is definitely a multidisciplinary team approach. We need the gastroenterologist, the surgeon, the pathologist, we need the radiologist, and we always need, obviously, a psychologist involved whenever possible. So it's a multi-team, and it's a decision that includes, and on that team is the patient, because that's really the person who has to come to the point of saying, yes, I need surgery, I want surgery. Either it's because there's major complications, they have toxic megacolon, they need emergent surgery, there's risk of perforation, etc., or it's a quality of life issue. There's early discussions. Surgery is a treatment. We don't want to say, oh, it's the last resort. We want it to be an upfront discussion when the gastroenterologist is talking about the treatments for ulcerative colitis. Surgery is one of those treatments that we discussed in the beginning. Provider team understanding and empathy, that is so key as well. When patients come to us, you know they don't want to be there because they're thinking, oh, I'm going to have a stoma or whatever, I really don't want surgery. But they've got all these feelings. So one of the things that we first do when we walk into the room is we sit down and we say, you know what? I am so sorry that you have been feeling so awful and you've had such a bad quality of life. We understand. And you know, when you sit down and you have that empathy with the patient right off the bat, you know, they're sitting there, they're anxious. I don't want to be here. There's all this going on. And you sit down and maybe you hold their hand, you put your hand on their shoulder, and you speak to them about what they've been going through and that you understand and you empathize. I can only say the tension in the room and the patient, it's like, oh my God. They do understand, and I'm going to be okay. They're going to walk me through this. It just makes a huge difference. And patient education obviously is key. If they're going to be engaged in this process of going through surgery and recovery, they need to be an engaged patient. They need to know what the expectations are and what they play in that. And here are the indications for surgery that is in ulcerative colitis. Failure, complications of medical therapy, dysplasia or precancerous tissue. They need to often go to surgery, and particularly we're talking about that high-grade dysplasia, because we know that it can be monitored for a certain period of time with chromoendoscopies, but after a point, they need to have surgery. Hemorrhage, obviously, colonic perforation and toxic megacolon, those are all urgent indications. Refractory extraintestinal manifestations, if they just keep continuing and getting worse, that's another indication. Growth failure, particularly in pediatric patients, and also younger patients as well with bad outcomes and decreased quality of life. And I have that in red because that really is an indication to go to surgery as well. Here's the contraindications, small bowel inflamed with Crohn's disease. That's Crohn's disease. We usually do not do a JPouch in Crohn's disease. One of the sayings is nothing like a pouch to bring out Crohn's. However, they will do surgery in patients who have never had any small bowel inflammation and who have not had disease in the anal area. But a huge caveat there when we talk to those patients is you could be at a little bit higher risk of developing Crohn's in the pouch. It's possible, and so we need to definitely monitor you. The other thing, like I said, the diseased rectal or anal canal and Crohn's or rectal cancer. The elderly patient, we will do surgery in the elderly patients, but they do have sometimes decreased outcomes as far as leakage of stool with the sphincters, so you want to be sure that you do test the sphincters in the older patients. But I'll tell you what, there's some older patients that are very young, they have a very active life. I mean, we do it in the 70s. There's some young patients who seem to be more like they're old. So, you know, you really have to know your patient and assess them, because the older patients can have good outcomes as well. But a lot of it sometimes can be a mindset too. And the morbidly obese patient, these patients as well, it's very difficult to bring the small bowel, make a JPouch, and bring it down to the anal area with all the fatty tissue there. And the in obese patients, the mesentery also is thicker, and so the small bowel doesn't stretch down as well. So these patients, we definitely have to talk to them, and when I talk about the stages, they need to lose weight before we would ever move forward with the JPouch. Because, and we learned that way back, when patients are heavier, you go to make the pouch, and if it don't reach down, you're done. They end up with a permanent stoma. So you really want to assess your patient prior to this. So here's how the JPouch is made. You remove the colon and the rectum. It's formation of a JPouch that's attached to the anus. It preserves anal sphincters, and it preserves the anus. It restores bowel continuity after having an ileostomy for a period of time. And it can be performed in 2 or 3 steps. So there's a diverting ileostomy between those steps. And I can tell you, when I first started, we were doing almost all 1 steps and maybe some 2 steps. But once the biologics came along and they were maintaining patients longer, I think, on meds, going through the different ones, patients were coming to us perhaps a lot sicker after being on long-term medical therapy. And the biologics just kind of changed things, and we would notice that they would develop pelvic abscesses when we were trying to do the pouch. There was just more leaks, etc. So now it's very rare we do 1 steps. It's mostly 3 steps and occasionally a 2-step. But here's stage 1. Removes the entire colon, the rectum remains in place, and they have an end ileostomy the first time. Stage 2, they come back 3 months between, the minimum of 3 months between, but it can be longer, particularly between this stage, because with an end ileostomy, they could go 6 months or whatever. The second step, the rectum is removed, the anus remains and the sphincters there, and they take the end of the small bowel, they fashion it into a J pouch, and that bottom of that J there becomes an open new rectum. It's their new reservoir. And you see the diverting ileostomy higher up. And here is the last step, which is just takedown or closure of the loop ileostomy. And there continuity of stool is returned. So when do we use that colectomy, that prior step? So we use it for patients who are on high-dose steroids or immunomodulators, biologics, because obviously wound healing, these patients are at a much higher risk. And this, technically making this pouch is very difficult. There's a lot of suturing, and then attaching it to the anus. If there's not good wound healing, we're gonna have problems. So we do this step first. Get the patient off the meds, get them back nutritionally optimized, etc. Toxic colitis would be another indication. You're not going to take somebody's surgery. They've got megacolon. Obesity, as I said before, we're not going to do a JPouch. You start out with this step. If they have marginal sphincter strength, we want to start out with this as well. If they have indeterminate colitis in the beginning, you have some of those patients that they can't really say they're this, or they can't really say they're Crohn's. They're somewhere in the middle, but everything kind of seems to say it's UC. This is the step we use first. We take the entire colon out. Often this gives us a better say from the pathologist whether, yeah, this really looks more and favors ulcerative colitis, or sometimes you'll get it back and geez, it kind of favors UC, but yet there's that deep fissuring that could be Crohn's, but yet we kind of feel like it's UC. So sometimes you can get a good answer when you got the whole colon, sometimes you can't, and you're still with indeterminate colitis. Patient desires to become pregnant. We know with the pouch procedure, pregnancy is at a little higher risk here of their ability to get pregnant due to often it's adhesions in there that may pull on the fallopian tubes down in the pelvic area. So we have some patients, if they're at childbearing age and they're ready to start a family, we'll do this step of the surgery. We let them go off, have babies. We have a couple of them. They come back in a year or two, and then we can move forward with the JPouch. So, and it can be a couple years. But during those times, we definitely want to monitor that rectum that's still in place, right? We're still going to monitor that because it still can be a source of ulcerative colitis, or they could develop a diversion colitis in that segment. So you always want to monitor it. And here, the patient not at high risk for pouch complications could undergo a two-step. Now, we'll do this in patients who their colitis is totally under control. They may be on Azalva. We've had some that are just on minimal therapy. UC has not been a problem, but they develop high-grade dysplasia or they develop a cancer. So they're going to need their colon out. So in those patients, there's less risk of decreased healing. So we'll go ahead and we'll do the colectomy and the JPouch in that one step with the diverting ileostomy. And then they'll come back later and we'll take down the stoma. And these patients do well. It's not common that they develop infections because they don't have the UC as severe. Here's how the JPouch is made. You see where it's the end of the small bowel that's made into a J, and then that open reservoir, and you see how it sits in there attached to the anus, and then you see there the loop ileostomy. So it becomes a loop ileostomy so that the third surgery is much simpler, and they just put the two ends of the bowel back together. Here's the other thing. There's a hand-sewn anastomosis versus a stapled anastomosis. In the hand-sewn, the pouch is attached to the anus. All rectal mucosa is stripped out, and they hand-sew that anastomosis. This is how all pouches were done when I started. Everybody got hand-sewn. And what we noticed there is that some of those patients would be at a higher risk of incontinence for maybe 6 months or so, because you're down in that area, and when you hand-sewn, you got to stretch those sphincters. And so the nerve sensation and sphincters are a little weaker until the healing occurs. And we found that 6 months to a year, this hand-sewn group caught up to the stapled group, where with the stapled group, we leave in 1 to 2 centimeters of rectal mucosa, because in that 1 to 2 centimeters is where the sensations for gas, liquid, and leakage, it sort of tells us, like quench, let's hold the stool in. So that 1 to 2 centimeters was pretty important. So now almost all anastomoses are performed stapled. I'll tell you what, it's also much easier for the surgeons to put in a staple in there and go around versus hand sewing. So my one surgeon still does hand sewn. He will do that for the cancer patients and anybody who has a primary sclerosing cholangitis, because that little 1 to 2 centimeters can still feed that disease. So he still does that for the select patients. Otherwise, he does the stapled as well. All the other ones pretty much do stapled. I can, say that obviously when you do the stapled anastomosis, like I said here, less trauma, preservation of sensations, technically easier, less tension on the anastomosis, there's less risk of stool incontinence and less risk of anastomotic stricture. When it's a hand-sewn technique, you have to be very careful because where that anastomosis scar tissue builds in and it's low, those patients were at a higher risk of also developing a stricture, and we have to make sure that we always do check the anastomosis to make sure it's open, or they would come back and need to have anal dilation to open that area up. Eventually that dissipates, though, after they're continually having bowel movements. The risk of dysplasia and cancer, those patients with stapled, they need surveillance. And so that's the part of the surveillance that we follow with these patients. It may be every 3 years, it just depends on what the risk is, or every year. Now the hand sewn, obviously that risk is less. They don't develop the anusitis or the cuffitis because in that 1 to 2 centimeters, it's not common, but they can develop ulcerative colitis in that little 1 to 2 centimeters. And when they get that, that's that constant tenesmus, bleeding and all of that. And then they need to be back on like steroid enemas or budesonide in that area. The higher risk of incontinence for the first several months and then diminishes with that hand sewn, and it's, like I said, used mostly in cases of dysplasia and cancer. Here's the diverting ileostomy. When they come out, they have the loop, red rubber catheter in place. It just helps it to be situated there, and then when they come back for a post-op clinic, that red rubber catheter slips right out. The patient with a loop stoma, obviously it's not a permanent stoma. It doesn't protrude out like a couple centimeters. So the loop stoma, much more difficult to manage. It's a little more flush with the skin. Often they have to use convexity to make it protrude out more so they can get a better seal. 20% of the small bowel is diverted with the JPouch procedure and that loop. So you can see it's 20% of the small bowel is below that stoma. Before it was an N, so risk of dehydration is very common at this stage. If they did not need antidiarrheals for the first step when it was N, I guarantee you at this step they are going to. They're going to need to really focus in on the foods to thicken their stool, and the Imodium or Lamodal or whatever is going to help do that. So that's a major risk, and you have to talk to your patients about that. Focus on the foods to thicken, the antidiarrheals. Normal mucus discharge from the anus is normal. So whenever, even when you have just the rectum left at the first surgery, they're going to have a mucus discharge in there. And it's real important to tell your patient they're going to have that and it's normal. Because they're like, wait, how am I passing something from the bottom? I got the stoma. Yeah, but you had the rectum in place, and here you have the JPouch. So you've got normal mucus secretions that go on that are going to continue down there, and they're going to feel the little sensation they need to pass it. Just go and pass it. Also, initially, they may feel a heaviness in the pelvis once this is formed because we're stretching the small bowel down into the pelvis and the surgery is down there, so they sometimes feel that little heaviness or pressure feeling, which is normal. It goes away. Some will sometimes tell me after surgery, I feel like I've got to bend over a little bit, and I said, it's just the feeling from bringing the pouch and all the mesentery down there. But it softens, you'll be able to stand up straight. So patient instructions, obviously after the continuity is restored and we take down the ileostomy, their initial bowel movements are going to have a few more. They may be looser. They haven't been eating in the hospital. They may have a little more gas because whenever you have surgery, you're manipulating the bowel. Gas is a common a thing that builds in the intestines, so you need to let them be aware of that. So they may have fewer bowel movements just because they're having more gas as well. Focus on high-starch foods that are going to act like a sponge and soak up the liquid. Salty type foods are very good. Do not drink on an empty stomach. I tell these patients, think of your system like a pipe. What goes in and how it goes in is how it's coming out. So if you drink first, zoom, out. There goes your energy, there goes all your nutrients, because your intestine has no time to reabsorb any of that. So eat something first that's going to act like a sponge, then drink. That food's going to soak up the liquid, which then slows down the transit time through the bowel, and then your intestines can reabsorb. Do not eat the biggest meal at night or late. We usually tell patients, eat your biggest meal before 7 o'clock at night. Eat your supper earlier. You can snack a little bit after, but that's going to almost guarantee you're probably going to get up in the middle of the night to have one bowel movement because you've ate so much late at night. Keep stools below 10 per day. 5 to 6 is best. It's kind of normal to have one at night. Use antidiarrheals. So when they're having these higher number of bowel movements and you're really trying to eat right, if you can't maintain that number down below 10, then start using the Imodium. And do not read the box, because the box will tell you, whenever you have your loose stool, take a pill or whatever. No, want you taking it before each meal and at bedtime. And start out with one a day, and if needed, we can then double up. But it's important to do that because I think that also helps train the pouch. It keeps things consistent and you get into a pattern. Use of fiber preparations is okay, like Metamucil. It gelatinizes things up as well, and some patients like to do that. Sexual function, dyspareunia, weak erections. This can occur when you're working down in the pelvis, and there's those nerves for urinary and sexual function. They get manipulated. So sometimes with women, there may be pain on sexual intercourse because those adhesions are there, and over time they soften. So I tell them, give it time. Don't stop having sex. Just keep trying, because it just all helps stretch that area out. But some patients I have to send to pelvic floor therapy if it just is uncomfortable. Weak erections, I can see this in men. Every now and then, it's pretty rare, and to be honest, with both of these, I think the laparoscopic approach has significantly improved in these two areas. The other thing you got to talk about with men that are heterosexual or whatever, can't have anal sex once you have the JPouch, because you're stretching that little sphincter area down there, and so we tell patients and we talk to them about that up front, no anal sex with a JPouch, or you're going to end up with incontinence. Urinary function, as I said, that's may be delayed in the beginning, and they may pass stool when they urinate, and that's okay, it's normal. If stool leakage, use moisture barrier ointments, protect the perineal skin. When they first come to us for pre-op, I give them all this calmoseptine or any moisture barrier ointment to protect the skin, because 10 bowel movements or more a day, you know what's happening down there. Butterfly incontinent pads, if they have a little leak in the beginning, they think, oh, let me just wear panty liners. No, panty liners protect your clothes. These anal leakage pads protect your skin because they go a butterfly pad right between the buttocks. So important for them to use. Wet ones instead of toilet paper. Acidic foods like bile salt stools, they get that burning discomfort in the anus. So I may order them cholecystyramine. Initially, they feel spasms in the pouch, and that's just because when the pouch is first starting to fill with some of the initial stool, it stretches the pouch. And as they're able to delay a bowel movement for longer periods of time, it helps the pouch expand into a little bit bigger size until it gets where it sort of fits the patient as to how they're eating. But that goes away as well. Food and stool diary initially may be very helpful so they can understand the relationship between what they're eating and how the bowel movements, if they're liquid, if they're solid, or how many they're having. And then the most important thing, function improves over time. So I see improvement in these patients as far as their bowel function. At 3, 6, 9, 12, 18 months to 2 years, you may see improvement in the number of stools, if they had any. But most of the time, by 6 to 9 months, most of these patients, and particularly your young ones, can be about where they should be with this. Supportive treatments I talked about a little bit, the antidiarrheals, the antispasmodics when they feel that spasming, or if you have a patient who also has irritable bowel, like an irritable pouch, that can happen and they go on that. Your bile salt binders, perineal ointments, acid-reducing drugs, and then obviously a lot of these irons, vitamins, and minerals are key. Here is what I give to my patients. I said, don't ever forget this. This is where I want you to be, and this is what you need to refer back to, because what I found is these patients over time develop that mentality that they had with ulcerative colitis. Oh, this is normal. This is just how it is because I had this. You know, their bowel movements are creeping up. They're up to 10. And it may occur gradually, and they're not thinking about it. Like I've had a patient call me, didn't follow up with me, calls me 4 years later. Thank God I was still there, right? He says. And he says, you know, my mom and my wife told me I need to call you because I'm having 15 bowel movements a day. They're all watery. You know, I don't really have leaks, but urgency. But, you know, Michelle, I was telling him, I think it's kind of normal. You know, I mean, I had ulcerative colitis, and it kept occurring gradually. Well, of course, I said, you need to come in. I need to see you. I got to go through what's been going on with you, and we're going to get a pouchoscopy. Sure enough, what do you think he had? Pouchitis. Has probably had it for 2 years when I asked him about his symptoms and everything, and hadn't got it treated. So that's why I really follow up on these patients. And you can see one at night, a bowel movement at night is not, that's okay, but a lot don't really have anything at night over time. The other thing is what I want to say is pasty consistency, stool, occasionally some get formed, particularly your young kids. I always tell them I want all their stools, 80% of the time, I want them to achieve a thickened output, because this group can get dehydrated too if they're having a lot of watery bowel movements. So that's sort of my gauge they understand. They can usually delay a bowel movement 1 hour up to 4 hours. I had one kid come in and tell me, Michelle, I drove all the way to Florida and I have to go to the bathroom. I'm like, what are you doing? You don't need to do that. And he goes, well, I thought I'd try and see what would happen, you know. And he goes, this was great. No urgency to pass stool. If they have urgency, it's probably pouchitis or cuffitis. Some may be able to pass gas, some may not. Most have no leakage of stool, but some do. And like I was saying, your more risk patients are your older patients. And if they do have something, it's a wetness. It's not an outpouring of stool where they have to change their bed linens or whatever at night. It's just a wetness. Use the barrier. They can eventually eat most foods, but in the beginning, I really want them to focus on the high roughage type foods. I don't want them to eat that because that will probably give them leaks or anything with high acid. So I tell them focus in more on those high starch foods in the beginning just to keep things in balance. But over time, most of them tell me, I eat most everything. And when I want to eat something high roughage, I go ahead and eat it, but I do it on a weekend when I know I'm going to maybe have some symptoms. So again, you can see my common theme, function improves over time. Here's a list of the complications. The biggest complication really is pouchitis. 50% overall can get that. And I really do see 50% of patients that develop it. Don't know why necessarily, but they do. Cuffitis is less. The leaks, that is only 6 to 10. So you can see most of these really are not necessarily that big. The Crohn's disease, 10 to 15%. Sometimes I feel like that risk is kind of going up higher over time because I feel like we're seeing a few more patients where they have an indeterminate diagnosis. And you know, as we say, we think IBD is a continuum of disease, and I just feel like we kind of get over to one side a little bit more with these patients sometimes. Pelvic vein thrombosis, very important. DVTs and blood clots are common with this group of patients, any IBD patient, and that is one of the 10 quality measures for IBD when it comes to surgery. Recognizing that in pouch patients there are complications, but also that the blood clots are one of the top complications as well that can occur, and all the patients are on anticoagulation when they go to surgery. Here's my follow-up. Initial adjustment phase I feel is really mostly in the first year, so I see them every 3 months, as you see here, to check their progress. Then yearly is needed to assess pouch function or potential complications. Additional visits if there's problems. Psychosocial assessment, just ask. You know quality of life. is key in these patients. Like I said, most are happy, but the young kids, depression, anxiety, the post-traumatic stress disorder, I see this in all the young kids. I always recommend they have a psychology referral, particularly the young kids. It's like you've gone through all these surgeries, and now you've had the surgery, and they all think, I'm going to be well instantly. No, there still is more time of adjustment, and then they come to the hospital, and it just kind of thinks about their drive coming back and the time that they've been so sick, and all that comes back in their life. So here you need antidepressant meds sometimes, anti-anxiety meds, referral for psychosocial counseling. Guarantee you, I spend 45 minutes with some patients with a JPouch. So I'm lucky, I have the time, I take the time with these patients to sit and talk with them. Here is assessment of an ileopouch. This is definitely what I'm looking for: the bowel movements, leaks of stool, perianal skin, ileoanal anastomosis, their quality of life, sexual function, I always assess, and medications. And one of the things I want to know is ibuprofen or Advil, because these patients think that once the colon's gone, maybe I don't need that. No, you do. You definitely do need it, because you cannot take that, because it can bring back ulcerations and things in the pouch. And I only learned that from my patients who would come back and were having symptoms of pouchitis, and I'm assessing what's going on with them. They had been in a car accident and had been on ibuprofen just steady for the last month and a half. Here is a stool diary. When the patients come back to me, I have specific questions I'm asking them about bowel function. I want them to do a bowel diary for me, because they can tell me that what they think or kind of remember is going on, but when they actually write down for the week, then they realize, oh, I'm going a little more than I thought, or, oh, I'm not going that bad. And obviously this is on apps too, so patients are coming with their apps with me for the whole week. And this is one thing to remember from a pouch: you can always go back to a permanent ileostomy. With a pouch, you can always go back, but not the reverse. So once you have a JPouch, we can't go back. You know what I'm saying? We can go back to have a permanent stoma, because we'll take the JPouch out and you have an end ileostomy. But if you've got an end stoma and that rectum and anus is removed, you cannot have a JPouch, because we got to have that anus there in order to connect. And believe me, there's a lot of people that used to call whenever they heard about the JPouch. They're like, oh, can I have that? And then I'm trying to assess, do you have your anus in? Well, how do I know if I have my anus in or my rectum? Are you having a mucus discharge from the bottom? Is it sewn up? Yeah, it is. Then we can't do a JPouch. So take-home points. Dehydration, high risk with a diverting loop ileostomy, okay? Very high risk, because remember 20% of the small bowel is diverted. Increased awareness of ileopouch complications. Quality guidelines, I'm talking about the DVT, so there's prophylaxis with that at every hospitalization with these patients, and also that there are pouch complications. Follow patients close the first year and yearly thereafter. Function improves over time. 90% of patients are happy with results and would recommend to others. So a lot of these patients are happy. Obviously, they're not going to be happy if they've had if they've had complications and they end up, where we're going to end up removing their pouch. Here's my surveillance of a pouch. Assess pouch function and quality of life at every visit. I have them complete a questionnaire. Digital assessment of the anastomosis. Always, because I want to check that the anastomosis is patent, and I can also assess if I feel like colitis in that retained segment in there of the mucosa. Perianal skin assessment, always, that's key. Yearly surveillance of blood work, and I get all the vitamins, minerals, CBC, CMP, iron, folate, all of these things that are crucial for these pouch patients. And then I also do a 3-year assessment of the anal transition zone for dysplasia if there's no risk. If there is a risk, then they need a yearly pouchoscopy. If they've developed pouchitis in the last year, I want to be sure that that's resolved with our treatment. If they have cuffitis, or there's a neoplasia in there, we need to check it. And if we're not doing a scope, if I do them yearly, I may check a CRP level and a fecal calprotectin. Because when I do the case study this afternoon, you're going to see that fecal calprotectin can sometimes preempt by 2 months that they're possibly developing pouchitis. So, you can't do scopes all the time on these patients, but we can do the fecal calprotectin or the CRP as markers of inflammation. All right? And this is what one of my patients sent to me. He was on a Capri Sun, and it said, respect the pouch. So that's what I say, respect the pouch. Don't ever underestimate it. And this is our multidisciplinary team. So you see, I have to work with the gastroenterologist, the surgeon, dietitian, send these patients to dietitian, psychotherapy. It is a multitude of, like we said, a village to care for them. All right, that's it.